and pick up with retroviruses. So what they're showing you here is how HIV has different characteristics that help it evade the immune system. So it's telling you infection of dendritic cells, macrophages, and CD4 helper T cells affects the immune system because you lose activation of the immune system and you lose control. Antigenic drift of a protein called GP120, basically this idea that because reverse transcriptase is so error prone, there are a lot of mutations that accumulate in the genome, and many of those can then be seen in the resultant protein. And so with the GP120, you get changes to the protein. And when you have protein changes, that can sometimes tell the immune system or make the immune system think that it's a different protein. And one of the infections that does something similar to this is something like relapsing fever, where you have the Borrelia spirochetes that get in the bloodstream. You mount an immune response, you generate an antibody response that gets the infection lowered significantly, but then the bacteria change the protein on the surface and they can regrow because the immune system has to re-respond. And so this ability to change your surface proteins, whether to put up different proteins or to change the proteins that are on the surface so significantly that they look like a completely different protein, allows the virus, the bacterium, the parasite, whatever, to evade the immune system. They also glycosylate that GP120 protein. They hide it with carbohydrates, which prevents antibodies from recognizing it. And they can spread directly from cell to cell. So I don't know if any of you took colloquium last semester in the spring. But one of my colleagues from Fresno State came and gave the first seminar, and she studies this thing called tunneling nanotubes, and it's structures that eukaryotic cells make that are little connections from cell to cell, and HIV can transit from cell to cell using these little connections. They can also form syncytia, which helps them hide from the immune system. So they have a lot of ways to hide from the immune system. So this is the slide that kind of gives you all of those numbers and characteristics that I was telling you about earlier. And so what will happen when a patient is first exposed to HIV, if we look at the yellow line is the viral burden or the viremia. During the early stages of infection, the viremia, the viral load, will peak. And when it has peaked, this is often when patients will experience the flu-like symptoms, that first sign of an infection. But what you see in the light blue is then the anti-HIV antibody. So the eventual antibody response is able to sort of tamp down the viral numbers, and you see they decrease significantly. And so at this point, the patient feels fine. They have no symptoms of having HIV. So unless they are engaged in routine screening for HIV, or perhaps are going to be with a new partner and are getting screened before that, they're not going to know they have HIV. So this is why they always recommend routine screening if you're sexually active, especially if you have multiple partners, or if you're, ended one relationship and starting a new one, to get tested. What we see in the dark purple is this overall T cell count, but specifically we're really interested in the CD4 positive T cells. And so you see when we have the acute infection, the number of T cells drops pretty significantly, and then it recovers a little bit. But over time, the number of T cells steadily decreases. And again, this may not be necessarily something that the patient notices. The body is pretty tolerant. These patients won't be experiencing those weird infections I was telling you about. But what I want to highlight is pretty much like right here where it says AIDS. And what we're looking at is that the CD4 positive T cell count has dipped below 200. The viral titer has gone above 10 to the 4. Okay. And the antibodies have started to disappear as well. So this is when really that idea that the CD4 positive T cell count has gone below 200 cells per cubic millimeter of blood, or basically like a milliliter of blood. So the T cell count is super, super low. Yes.
So even when the virus load is like super low, it can still be detected.
Mm-hmm. Yeah. And what they talk about now, and we'll get to it in just a little bit as well, is some of the newer, the more modern HIV therapies keep the viral load so low that they call it undetectable. And the idea would be, in theory, I don't know if I'd want to risk it, but in theory, if a patient is on those drugs and has a viral load that is medically classified as undetectable, in theory, they are not able to transmit the virus. In practice, would I feel comfortable with that? Probably not. That's up to every person to make that choice. But that's the premise.
Studies on that, though?
They have. I would just always be afraid that I'd be the exception.
So with the treatment they receive to keep their viral load down,
Mm-hmm.
Does that make the HIV infection like less, the morbidity? Does it decrease it?
In theory, it should also keep, so while it's keeping the viral load down, it should also keep your CD4 positive T cell count up and prevent you from developing those complications. You know, I don't know how many of you know who Magic Johnson is. Sometimes I like name celebrities and that were really famous when I was a kid, and people are like, So I don't know. Magic Johnson was a basketball player, and he was one of the first celebrities, athletes that was HIV positive. And he's been living with it. I mean, he's still alive. And he announced that he had it in, I want to say, the early 90s. So, you know, why was he lucky and people like Freddie Mercury died? So it really depends on a lot of factors, because, you know, a lot of the celebrities, the dad from the Brady Bunch, like, they had enough money to buy drugs, to buy the treatment. But some of them lived and some of them didn't. And I think we still see that now. But now the therapies are even better, where more and more people are able to die of things that aren't HIV or AIDS related. They could die of old age, or maybe they die of a different kind of cancer or heart disease or whatever. So the therapies are really good.
So it's kind of, HIV and cancer kind of similar, like cancer, same thing, some people survive and some people die.
Yeah. I mean, in the early 80s, it basically was a death sentence, and people died pretty quickly. By the early 90s, there were more therapies available that helped to keep people alive.
Are you more likely to transmit HIV like in the first couple of months compared to like that, like, in that period when you don't have any symptoms? Or is it like the probability of you transmitting it to somebody is the same like throughout the entire?
I would say when you have that peak, that's when you're going to be most likely to transmit it. But if you're keeping on the therapies and you're keeping your numbers low, I think the risk is probably lower than like in here. And so this is just kind of a refresher of like, what is the function of a CD4 positive T cell? Why does infection of just this one cell type basically lead to the overall collapse of the immune system? Well, it's responsible for growth and control of the innate immune response, growth and control of B cells, growth and control of natural killer cells, other CD4 positive T cells, CD8 positive T cells, activation of epithelial cells, neutrophils, and macrophages. So when you lose the CD4 positive T cells, what you lose the control of bacterial infection, intracellular bacterial infection, fungal infection, viral infection, tumor progression, and HIV progression. Because CD4 positive T cells, these helper T cells, are so critical for activation of the immune system, when they are gone or when their numbers are too low, that's when you have all of these other infections that will pop up that you can no longer control. So in terms of like the epidemiology, this is the prevalence of HIV in adults by World Health Organization region. So the highest rate is, of course, in like sub-Saharan Africa, and then in the Americas. And they group North and South America together. But if you look at the numbers, the prevalence in Africa is 4.1, the prevalence in the Americas is 0.4. Or 0.5, excuse me. So it's orders of magnitude less common, less prevalent in other parts of the world. So known routes of transmission, I think most of us are familiar with how people get HIV. Inoculation into the blood. This can be through blood transfusions. So this is why hemophiliacs were sometimes classed as that 4-H club. Needle sharing among intravenous drug users. There's your heroin addicts. Needle sticks, open wound, mucous membrane exposure in healthcare workers, tattoo needles. There was a case recently some cases recently out of, I think, New Mexico, where people were getting something called a vampire facial that involved needles and blood. And I'm like, if I get a facial, the last thing I want is somebody like stabbing me in the face. But some individuals who had that procedure done got HIV because the clinic wasn't sterilizing their equipment properly. Okay. Sexual transmission, and then perinatal transmission, so from an infected mother to the fetus. Routes not involved in transmission, close personal contact, so household members. If you are not having unprotected sexual intercourse or not, exchanging needles with somebody in your house, you're not going to be getting HIV from them. So hugging, kissing, holding hands, right? That's not going to transmit HIV. Healthcare workers who are not exposed to blood, you have no risk of getting HIV from your patients. So what are some of the infections that people who have HIV that has progressed to AIDS classically present with? So I told you that the initial symptoms of infection resembled the flu or even like mono, that tired, achy, fever, maybe a headache, and the symptoms will resolve in 2 to 3 weeks after symptom onset. So a lot of people will just think, oh, flu, mono, blah, just don't feel good, right? Your brain doesn't go, oh, maybe I have HIV. So what we're looking at here are some of the infections that people were presenting with that really made doctors very confused. So one of them that made doctors very confused is this pneumocystis pneumonia. They had almost never seen it in patients, except for patients who were basically had their immune system wiped out from chemotherapy. Toxoplasmosis, not at all common as causing disease in healthy adults. The Kaposi sarcoma, which is one of the herpes viruses, one of the human herpes viruses. These non-tuberculosis mycobacterial infections. So those were some of the ones that were pretty, they really stood out to clinicians. Why do I have, all of these patients in my hospital who have pneumocystis pneumonia? I've never seen it before, and now I have 10 patients with it. I don't understand. And what happened to their immune system? What do they all have in common, right? And that's how epidemiologists and clinicians started to figure out, well, there is something going on that is wiping out people's immune systems. But again, these are some of the infections that we see. protozoan, toxoplasmosis, some of the other protozoans, unicellular eukaryotes, that's what protozoans are, that cause diarrhea. Candidiasis, this is the same fungus that causes yeast infection. So like the overgrowth of fungus that some people experience in the vagina, like a yeast infection, but there are otherwise healthy adults that have it in the throat and the lungs. The only other time that it's fairly common to see candidiasis is in children, in newborns. They can get it in their mouth. We call it thrush. Okay. Other fungal infections like cryptococcosis, outside of the lungs, it's normally only in the lungs. Disseminated histoplasmosis or coccidiomycosis. We'll talk about fungi next after viruses. Cytomegalovirus, herpes simplex, a couple of the other viruses that we didn't talk about, Epstein-Barr, weird bacterial diseases, opportunistic cancers, and others. It sometimes can go to the brain. Sometimes people just waste away. So AIDS occurs when the CD4 positive T cell count is below, it should be 200 milliliters, not microliters, 200 milliliters of blood. And the viral load is, again, like right about 10 to the 4, 10 to the 5 with the onset of one of these diseases.
What do you mean wasting away?
Basically like a type of anorexia where their bodies like physically waste away. Like if you look at pictures of AIDS patients from especially the 80s and 90s, I mean, they're like skeletal. So it's like a fatal type of anorexia. Okay, so this is an early case of HIV/AIDS. In July of 1981, a 27-year-old man complained of painful urination, fever, chills, night sweats, weakness, difficulty breathing, cough with sputum, anorexia, and a 16-pound weight loss. So again, in a patient who is losing weight and is not trying to lose weight, that is of concern. For the past 7 years, he had been receiving up to 4 monthly infusions of factor VIII concentrate to correct his hemophilia. So hemophilia is a blood clotting disorder, and so hemophiliacs often required blood transfusions. They don't usually make platelets appropriately, and there are a number of genetic mechanisms behind that. But if you give them blood transfusions, especially like packed with platelets, that can help them prevent blood clots. And that was known even in the 70s and 80s. So he received those infusions to correct his hemophilia. He did not have any other risk factors for HIV infection. So he's not a drug addict, he's not a homosexual. Those were the major risk factors at the time. In August, so 1 month later, they could see that he had infiltrates on a chest x-ray. By September, those are his blood results. So his hemoglobin, 10.7. Sometimes they won't even let you like give blood if your number is below 11. So that can indicate anemia. White blood cell count was starting to get kind of low. IgG was present for cytomegalovirus, Epstein-Barr, toxoplasma, hepatitis B. Immune deficiency was suggested by a lack of response to tuberculin, mumps, and candida skin tests. He had that pneumocystis pneumonia. He had thrush, which is the Candida albicans infection in the throat and mouth. In May of 1982, so not even a year later, he developed an enlarged spleen and enlarged lymph nodes. So he came back to the hospital. His white blood cell count had gone down in half. Only 11% were lymphocytes. So leukocyte is white blood cell. Lymphocyte, generally we're talking B and T cells. At this time, he had Mycobacterium avium in the bone marrow, lymph nodes, and in granulomas. Total lymphocyte count went down even more. Levels were not responsible to stimulation. In July of 1982, 1 year later, there goes his lymphocyte count again. CD3 positive T cell count, even more down, very low. You should normally have more, you should have twice as many CD4 to CD8 positive T cells. He had very few CD4 positive and 4 times more CD8 positive. So his ratios were off, his numbers were down. He continued to deteriorate, and he died at the end of September of 1982, so just over a year later. Cytomegalovirus was isolated from his lung and liver, Mycobacterium avium from most tissue samples. In 1981, AIDS was a newly described disease. HIV had not been discovered. Monoclonal antibodies and immunophenotyping were new technologies. This patient acquired HIV infection before routine screening of the blood supply. So again, you're looking at this idea of we didn't know what it was, and I wasn't even alive. We, scientists, didn't know what it was. They knew there was something that was causing this total crash of the immune system. They saw it in certain patient populations. They figured it was probably bloodborne because of the patient populations. And eventually they were able to isolate the fact that it was HIV. You can test it. Usually the primary screening is an antibody test. The risk of an antibody test is, remember, you don't generally make antibodies right away. So if you have a possible more recent exposure, you can look for early markers of infection, like the presence of viral antigens rather than the antibody response. The CD4 positive T cell counts, the CD4 to CD8 T cell ratios are indicators of disease. So again, that primary screening is an antibody test. If the antibody test is positive, it's usually an ELISA. They will do a secondary test, which is most likely a Western blot to confirm. And if they want to quantify how much virus you have to say whether or not you have a high or low viral load, they can do reverse transcription PCR to look for the viral RNA. They can also look for the presence of the viral DNA that has integrated into your chromosomes. So, if you're working in a clinical setting, if you have a patient who has possibly been exposed to HIV, this could be a sexual assault victim. It could be somebody whose partner was like, oh, by the way, right? Which in some states is actually illegal. If you don't disclose that you have HIV, it's a type of assault. So you have to disclose that in some states. So if you have a sexual assault patient, if you have somebody who's just figured out, maybe my partner had HIV, if you have a healthcare worker who is exposed, like with a needle stick or something, and a patient may have had HIV, the early screenings may not be sufficient, and so you'll have to do more screenings. Okay? Or you'll have to do screenings for an extended period of time. And I know this from not like secondhand experience. I have a friend who was the manager at the bookstore where I worked when I was in college, and one of the customers bit her. She was crazy. So she bit the manager on the hand because she was shoplifting, and my manager was like, you can't shoplift. So she threw the books down. My manager picked them up, and she grabbed her hand and bit her, broke the skin. It was really bad. So she had to get testing for all these bloodborne pathogens because, biting, causing wounds, that can transmit viral infections. And she had to be screened for HIV for 6 months before they finally were like, okay, you don't have HIV. They knew it was her when they went to arrest her because she left the store. The cops saw her at a bus station, and they were like, okay, they were trying to talk with her, and then she bit one of the cops. So they knew it was her. She got him right in here, and they said that, I didn't see it because I was at home, but they said he had to with the baton to get her off because she was like, ah. Okay, but that's the thing. Your patients who may have been recently exposed will have to be screened again. Even if a patient is coming in for routine screening, no doesn't mean no. No means maybe not yet. And that's why they recommend, especially if you are not in a monogamous relationship or if you are a drug user, you get screened frequently. Okay. So some of the therapies include things like inhibitors of viral binding, because viral binding is so specific. Right? It binds to that CCR5 receptor. If you can block that receptor, you can block the virus from binding. If you can prevent the virus from fusing, that's great. But the one thing that the three things listed here that HIV has that a lot of other viruses don't, they have the integrase, which is necessary for integrating the viral DNA into the genome, into our chromosome. That is very unique. They have the reverse transcriptase that allows them to convert their RNA genome into that DNA. And they have protease. And you might be like, what protease for? What happens during HIV transcription and translation is they make this like big massive like protein that's all the proteins combined. So they need protease to break it up into the individual proteins. So they translate like a super protein and they bring their own protease to kind of break it up into the individual proteins. So HIV actually has a handful of really attractive targets that are unique to HIV. And so we have now this highly active antiretroviral therapy. They call it HART. So it's a combination therapy. It's a combination of a number of different inhibitors that works pretty well at keeping the viral load down and preventing that progression from HIV infection to AIDS. And then in terms of preventatives, education is really the primary infection control. Don't engage in unprotected sex. If you are going to engage in unprotected sex, make sure that you and your partner are screened regularly. Don't use IV drugs. Don't share needles. If you are going to use IV drugs, get fresh needles every time. That's why cities have a lot of major cities will do needle exchange programs. And people get all like, you're promoting drug use. It's like, well, no, we're trying to stop HIV. They're going to do drugs anyway. We just would rather them not spread HIV and hepatitis and stuff through the population. And it's the same thing with condoms. There has been a very big uproar because one of the things that they tried to do in Africa to help reduce the HIV prevalence was to distribute condoms. And the Catholic Church, like, oh my, you can't give them condoms. I'm like, well, clearly they're doing something anyway. The prevalence is so high. Condoms aren't going to encourage them to do it more. They're already doing it. We're just trying to stop the transmission. So that education is really important. Yes?
So, what about kissing if they do kissing this time?
It should not, no. Because you don't have open sores. But the thing with a bite is if you're breaking skin and the saliva is getting into an open wound, that's possible, especially if the person doesn't control the HIV. So uncontrolled HIV could, in theory, spread from saliva to an open wound. What stopped HIV from spreading in blood transfusions was screening of the blood supply. And you may or may not have heard that at least in the US, the FDA for the longest time, if men who had sex with men were not able to donate blood ever, because that is one of the more risky sexual behaviors that can transmit HIV. And then they said if they have not engaged in the behavior in a year, so in the past 12 months, then they could donate blood. And I want to say they've started to kind of even walk that back now, where they're starting to open up the blood supply to more and more donors. In other countries, they don't have all the same restrictions. That's just in the US. Like in Canada, they allow everybody can donate blood, just has to be screened. PPE, those of you who are going to be working in a healthcare setting, right? You, of course, wear PPE, try to avoid needle sticks. If there are surfaces that got contaminated, disinfect them. So if you have a patient who may have been HIV positive that got blood on a surface, decontaminate it, right? Disinfect it. If you go into dentistry or something and you should be autoclaving all of your tools every time, dental offices should have an autoclave and they should be sterilizing their tools every time. There are no vaccines available yet, but a lot of biotech companies are working on them. especially using the same mRNA technology behind the COVID vaccines. And there is what they call it PrEP, pre-exposure prophylaxis. The trade name of the drug is Truvada, and it is a combination of 2 reverse transcriptase inhibitors. So the idea here would be that, again, patients who engage in what are called high risk, and I'm not passing judgment on any sort of behavior, it's just what they call a high risk behavior. Patients who engage in high risk behavior can use this pre-exposure prophylaxis. They have to take it regularly. And again, in theory, if they are exposed to HIV because they already have these drugs circulating in the bloodstream, they should not develop the infection. And in theory, that has, in practice, that has actually worked really well. So if you do have an HIV patient who is taking their antiretrovirals regularly, they're following their regimen, they could be undetectable. Patients who are taking PrEP should, again, in theory, not be able to acquire the infection. And this is supposed to be to help lower the prevalence of HIV, especially in communities where it is higher. And circumcision is actually thought to be protective, that men who are uncircumcised are more likely to acquire HIV infection and transmit it to their partners. So that's like, I don't even want to get into it. Like, I'm on Reddit and I'm in all these like pregnancy groups, and these people just like go off on circumcision. My kids are girls, I don't have to worry about it. But man, there's a lot of debate about it. But in practice, circumcision has been shown to lower rates of HIV acquisition. Do I think everybody should be circumcised because of that? No, I don't think so. But it's a thing. Okay. Questions about HIV?
So if somebody were to donate blood,
Mhm.
and since they tested blood, if they have like an HIV positive blood, do they tell the patient? Oh,
Mm-hmm. Yeah. And when people are diagnosed positive with HIV, there will be an epidemiologist who works for the public health department that is supposed to inform potential partner or like previous partners that they have potentially been exposed. They try to gather all that information.
Wasn't there like a thing now where I think it's like a website or like something where you can, if you don't want to tell them yourself,
Mhm.
it like sends, like you put in all the information and it sends out like a mass text to them.
Mhm.
Like, hey, you consensually been exposed. Or something.
Yeah. There's something like that. And again, the public health department will do it too. The only challenge is if you don't know the contact information for the person that has been potentially exposed. So again, I think one of the really interesting things, and I was talking to a couple people after class on Monday about this, is that a lot of people think that the first time we saw HIV in the US was in the early 1980s, and that is not the case. There are patients who died in the 60s and 70s that have since either had their remains tested or like their samples that were left over after they passed away that have tested positive for HIV, or based on the collection of all of the symptoms, it appears they had HIV. And one of the first was like a 15 or 16-year-old boy who, what they say is that he engaged in prostitution, but I think the way that we would say it now, because 15 and 16-year-olds can't consent to be prostitutes, is that he was probably a victim of sex trafficking. So that's a risk too when you have teenagers who are put out on the street and that's what they have to do. And then there was another prostitute who was an adult, so in theory I guess you could call her a prostitute, in the 1970s who gave birth to 3 infants that all died, and she died too, and it turned out that they were all HIV positive. So it was around in the US longer, but it didn't hit that kind of critical mass, like, well, a prostitute died in San Francisco, a teenage prostitute died in St. Louis. You're not making these connections. But when 30 gay men turn up at a hospital in New York City, everybody's like, what's going on? Why are there so many of them all of a sudden? Right, so it's when it really hit that critical mass that it became something that we paid attention to.
What's the likelihood of it being passed on from like mother to child?
So that's a good question. In mothers who have their virus appropriately controlled, they now can give birth to children who are HIV negative and can even breastfeed. So I think I talked a little bit about the scientist in China who made like CRISPR babies that were supposed to be resistant to HIV. And the thought process behind that was there were a handful of couples where the mother was HIV negative, but the father was HIV positive. And so if they were to conceive, there would be a risk that the father could transmit HIV to the mother or to, and then therefore to the child. And so they did this whole like weird CRISPR thing when literally all they do IVF for families where the father is HIV positive. They wash the sperm. And there's no risk of transmission because the virus is not like in the sperm cells, it's in the semen. So you wash it away and then you can do the injection of the sperm cells in and there's no risk. So you don't have to make CRISPR babies. There was like no point. I'm like, you don't have to make CRISPR babies, especially when you do it wrong. Yeah. The only reason to make CRISPR babies is because you want to. Oh, yeah. A cure? A cure for HIV? Mm-hmm. Yes. So there have been a handful of patients worldwide who have been cured of HIV infection, and it's because they had bone marrow transplants. So it's when, and it was for like a cancer. They had to have a bone marrow transplant. So the entire immune system was wiped out, including all of the infected CD4 positive T cells. They were provided a brand new immune system through a bone marrow transplant, and they were HIV negative following that. Yeah. And so then you might think, well, why do we not just do bone marrow transplants for everybody who has HIV? Well, one, you have to find donors. And at least in the US, unfortunately, the patient population that has the highest prevalence of HIV tend to be minority patients. And there are fewer donors. You're more likely to find a compatible donor outside of your family if you have the same racial or ethnic background. So if you're already an ethnic or racial minority that has HIV, which is where we see the highest patient populations, you have very low chance of finding an outside donor. So finding a donor is difficult. But let's say you do find a donor. A bone marrow transplant without insurance costs $1 million.
Wait, for a bone marrow transplant, why is an outside donor better than like
I'm not saying an outside donor is better, but sometimes your family is just not compatible.
Oh, okay. I thought
Yeah. And then especially, it's even more challenging if families are mixed race.
Yeah.
Because then you have to basically find like the same combination. Yeah. So it can be really challenging. But yeah, my sister-in-law had leukemia and they were telling her, oh, bone marrow transplant. But she had insurance, but still they were like, oh yeah, it's about $1 million. I'm like, oh. So if you don't have insurance, you basically get to die. Like that's your choice because you can't afford it. So that's why that's another reason why it's not a viable option for curing HIV at this point. But yes, there are a handful of people who have been cured. Yeah. $1 million, save up just in case you get cancer.
Pick me out a nice I was like, pick me out a nice
Well, the millennials, we too much avocado toast in Starbucks. Now we can't afford our coffee or our cancer treatment. Can't buy a house. I had avocados. So, but yeah. So again, in theory, it works, and it has worked definitely. It's just like the difficulty in finding the donor and then the cost involved. It just makes it too difficult to do something regularly. Now, if medicine gets to the point, and I believe it probably will because we make so many advances all the time, if medicine gets to the point where finding a compatible donor or even like somehow using CRISPR to like re-engineer your own blood supply, that would be awesome. Because I think they've just finally approved one of the first CRISPR treatments for sickle cell.
So you know how people say their stem cells like from the umbilical cord?
Uh-huh.
Per se, if you say that and use that, would that be a possible
Yes.
treatment?
Yes.
Has it
And
been done?
I don't think so. Only because I imagine that the Venn diagram of children whose cord blood has been banked and children who are HIV positive is not overlapping yet. But as more children whose cord blood has been banked become adults and potentially develop HIV, that may be something that they could look into. But that would be the best. Or if they could develop a way to turn your stem cells, like one of the challenges with stem cells is that they end up like semi being differentiated. So you have like skin stem cells and fat stem cells. And you can't really go backwards. You can only go forwards. You can further differentiate, but you can't like undifferentiate them. So if you could like undifferentiate adult stem cells and put them back into the patient, that could, in theory, work as well. So we just need some more medical advances. That's basically it. Yeah, stem cell biology is really cool. But that's like the holy grail. They call them induced pluripotent stem cells. If you could take your adult stem cells and turn them back into basically the embryonic state. And then there'd be no rejection issues because they're yours. They're yours. Okay. So real briefly, we'll start talking about hepatitis. And then next week we'll hit prion diseases right before Thanksgiving and some fungal infections right before Thanksgiving. So that'll be fun. Things to talk about over turkey dinner. So hepatitis is not a taxonomic classification. Hepatitis describes at least 6 different viruses that cause liver infection. So again, when I say it's not a taxonomic classification, these viruses are not genetically related to one another. Some of them are DNA-based, some of them are RNA-based. But they target the same organ, so they're classified together. So they differ in structure, replication, time course of disease, etc. So the more common hepatitis viruses, A through E, there is also a G. There used to be an F, but it turned out it wasn't a hepatitis virus, so it had to go. So A through E. A and B are more common. C is also relatively common. E is not terribly common, and D requires co-infection with B. So again, it's kind of, they're a little bit different. When you compare, and again, I'm not going to necessarily be like, oh, can you tell me all the genetic material and draw a chart like this and compare and contrast all the hepatitis viruses? Like that's not really, the point or very helpful for you. But some of the things to think about are, what are the more common routes of transmission? So how do people get these hepatitis viruses? What are the risks to the patient for these different hepatitis viruses? And so, how would you diagnose them? What do you need to think about? So we're going to talk about the major ones and how you recognize and tell them apart. But this chart kind of summarizes everything we're going to talk about. So hepatitis A is one of the P coronaviruses. So it's a naked positive sense strand RNA genome. So you have to think back to your P coronaviruses like rhinovirus and polio. It is very stable because it doesn't have an envelope. It's naked. It is sometimes called infectious hepatitis. It is transmitted through the fecal-oral route and is sometimes associated with foodborne illness, especially outbreaks in restaurants if there's a member of the staff who is infected and has bad hygiene. Okay, so again, it's stable, and that's why it can be transmitted through the fecal-oral route. It survives the stomach. It's not destroyed by stomach acid. It can be inactivated by chlorine treatment of drinking water, formalin, different acid, UV radiation, completely cooking your food. Okay. Hepatitis A is also sometimes called acute hepatitis. This one, it doesn't usually persist in the host. So it's acquired through ingestion because it is a fecal oral. You get it? It is not usually cytolytic, which with naked viruses they often are because they cause the host cell to burst. Instead, it's released by exocytosis, so it just kind of gets exported out of the cell. So it's ingested. It crosses through the intestines. So it actually, in the P coronaviruses, you might remember there's a whole group called the enteroviruses that are all transmitted via the fecal oral route, but none of them cause intestinal symptoms. So that's what, like polio, right, is a nervous system disease. Hand, foot, and mouth causes those like, well, in your hands, feet, and mouth, which is not your intestines. So this one will go from the intestines to the blood to the liver. So it's not affecting your GI tract, it's affecting the liver. It is then shed in the bile. So the liver is connected to the intestines, like through the bile duct. The viral particles can then get into the stool through the bile. And we call it an acute infection or acute hepatitis because it doesn't cause a chronic infection. The majority of patients will resolve the infection. It is also not associated with cancer. Hepatitis B and hepatitis C are. So hepatitis A is not generally associated with cancer. And it is, again, one of the more common hepatitis viruses. Approximately 40% of hepatitis cases are hepatitis A. It spreads rapidly because people are contagious before they have any symptoms. So they could be shedding the virus in their feces if they don't wash their hands very well and then prepare food. It's very likely that they can transmit the virus that way. So what we see, ingestion of virus, within a couple of weeks, you have virus in the feces, and then you'll develop the viral specific antibodies. The incubation period is generally a couple of weeks. You can have elevated serum liver enzymes and the icteric symptoms. So icteric symptoms basically means jaundice, you turn yellow. So if a patient, especially like in the whites of the eyes, but also just kind of in the skin tone as well, in some patients, you may not see like the skin color look more yellow, but the whites of the eyes will start to look yellow. That always indicates something's wrong with the liver. So it's generally diagnosed based on symptoms, especially jaundice, and known exposure. Everybody, this one restaurant, everybody who ate there's a lot of patients turning up with hepatitis A. You ate there too during that time period. They can do an ELISA to look for the antibodies, but they can also do passive immunization during the incubation period. So using pre-formed antibodies if you've potentially been exposed. You ate at the restaurant during the time period and everybody's starting to get hepatitis A, but you haven't developed symptoms yet, they can give you pre-formed antibodies. But there is also a vaccine. So hopefully you have been vaccinated against hepatitis A. And that should prevent you from developing the disease at all. Hepatitis E causes very similar disease where you're going to see the elevated liver enzymes, you're going to experience maybe that jaundice, but it has a higher mortality. So if we go back to our chart, this is the last thing, I'll just show you the chart again. Right. You have mild disease, abrupt onset, don't develop carrier symptoms. But then here with hepatitis E, you get the abrupt onset. Normal patients have mild disease, pregnant women very severe. The mortality rate with hepatitis A is less than 5%. It's because of liver damage. But in normal patients, 1% to 2%, pregnant women, 20%. So it's dangerous. Hepatitis E is just a little bit more dangerous. And it's a different family of viruses. Okay. So we'll pick up on Monday of next week, because we don't have class on Friday. We'll pick up on Monday of next week with hepatitis B, and then C, and then prions. So you don't want to eat anything, basically. You're going to get a prion disease.